Okay, let's do this. So, hi, everybody. My name is Boris, and I am the Medical Education Director at Zuron, and I'm joined today by Dr. Andy Gunter, who is one of our advisors here at Zuron. So, as for me, just a quick introduction. I come from a medical background, but the last 11 years have been fully dedicated to medical education. And I spent a lot of time in continuing medical education as well as educational technologies within healthcare. And I've been with Zuron for 7 months already. And I'm very honored to have Dr. Gunter here with us today. Dr. Gunter, would you mind giving us a bit of background on you?
Sure, that'd be great. Thank you, Boris. I appreciate it. So, I'm a practicing physician. I've been in practice for over 20 years. I'm pretty close to 25 now. I kind of round down a little bit instead of up. I've been in hospital leadership. I've been in private practice. I've been in group practices. I've managed teams and operations. I've actually done medical missions, so you can enjoy the background of the pyramids where I went to Egypt fairly recently. But I've also been involved deeply in medical education, specifically teaching residents, PA students, nurses across all levels, and really have really honed my skills to try to do my best to bring this next generation into better education and academics and medicine.
So today we'll chat about OSCEs, or Observed Structured Clinical Examinations, as a lot of clinical educators are familiar with. And maybe we can start by taking a step back into the past. And um, communication and interpersonal skills have been or are an integral part of being a good clinician, whether you are a physician, a nurse practitioner. But historically, these skills have not been front and center within education that we receive. And they are extremely important, but they have historically kind of taken a step back to technical and more traditional clinical knowledge. So, Dr. Gunter, why do you think that in historically there hasn't been enough emphasis on teaching these skills? And how are students expected to learn these skills, such as communicating effectively with patients and teamwork skills in the past?
Great question, Boris. Excellence in communication and interpersonal skills has not really been a focus in regards to medical education. And if you think about it, medical schools and residencies have really focused on the academics, right? They want to get the brightest of these kids, and that's important. Don't get me wrong. But that being said, medical training programs are now really looking at those soft skills of communication. This becomes very important in clinical practice. The biggest part of that now is patient experience and patient satisfaction. Um, this has evolved over the past 5 to 10 years. For example, you could be a brilliant provider and see a patient in your office, but the moment they leave, they receive a survey. They're asked, how did your provider, your caregiver make you feel? Um, did they communicate everything clearly? Do you have everything that they need, that you need now as a patient to understand the diagnosis and treatment? And that information, that survey is given to the provider, it's given to their employer, it's actually given to the public, so publics can see how does this physician or caregiver really communicate with their patients. You're going to get a star rating, just like anything else that you see on Amazon or Google, you name it. So these surveys are critical to understand that soft skills need to start coming to the forefront. Medical schools and administrators are not just looking for the best, not just looking for the brightest, but also looking for the best communicators, because how you convey and how you convey information becomes more and more important when you're talking to patients. And school administrators and residency programs are starting to recognize that.
Okay, that makes sense. And let's fast forward to today, and tools like OSCEs are essentially a cornerstone of how we teach and assess these skills in schools. But they generally seem to focus on a really narrow set of scenarios and are very structured. And so can you tell us how are OSCEs currently being used today across medical schools and other healthcare schools to evaluate communication and interpersonal skills specifically? And do you think they're covering enough ground?
So OSCEs are typically valued in the third and fourth years of medical school. The first 2 years, traditionally, whether you're in the US or even in some of the international medical schools, the first 2 years are basic pathology and physiology of disease. It's such a massive volume of information that it's really hammered into students those first 2 years on academics. Programs are starting to try to bring in more clinical skill and soft skill development into their programs in their first and second year, but they're really limited in time because of all that volume of information these students are trying to obtain and then use practically. So typically these OSCEs have occur during their third and fourth year rotations. So after their primary rotations, such as pediatrics, internal medicine, family medicine, OBGYN, and surgery, these third year students after that rotation will do an OSCE with a mock patient, typically one per rotation, that really allows them to simulate a patient that they may or may not have seen previously on their rotation, and it just allows a more objective measure for administrators and physicians that are grading them to see how they deal with patients, not only in those soft skills of communication, but also on the hands-on practical of knowledge of differential diagnosis and being able to write a note.
Yep, absolutely. They have a very important role in traditional and current medical education. But as important as OSCEs are, they do have their barriers associated with them. Two that pop into my mind are financial and staff and resource management. Um, what do you think are the main barriers that organizations and schools face in using OSCEs effectively, especially when they're trying to teach communication and interpersonal and teamwork skills?
Sure. I can add to those. I can think of a kind of the big three. Some of the big barriers are time constraints, right? So to this point, physicians who are seeing patients in the community are typically being called in for a day to observe these students. So, healthcare, time is money. If you're not out there practicing and you're just helping students, wow, that's amazing. And it's certainly something we in academics do very often, but you're still kind of in that losing money phase for the healthcare system you often work for. The second part is you have to have a follow-up. So not only are you observing these OSCEs in a controlled setting where you're sitting there and you're watching them on camera, you're taking notes from the rubric that you've been given to go through the OSCE with the student. You then have to kind of create your own analytic of that, and then meet with them and follow up with them and say, hey, look, all right, now I need to take another day or half a day to sit down with each student. I've done these before, and typically, you've got about 10 to 15 students that you have to do these for. So there's a big time commitment when it comes to actually observing them, but there's another time commitment to sitting down with them. And typically that's going to involve maybe about a 10-minute per student session. So there's easily 100 to 120 minutes of sitting down with students and trying to bang out what they did really well and what they didn't do well. And here's your written feedback and good luck on your next OSCE. So that time constraint really comes into play. The second part is financially, right? If you're looking at how much it costs per student, there are publications going back as far as 2015. It's looking to be about $900 a student. Now, that doesn't sound like much, but if the average school size is around 135 medical students, you're talking about $122,000 a year to do OSCEs. And that doesn't take into any account of upgrading systems, upgrading cameras, upgrading microphones, paying volunteers, and those incentives really can be a struggle. And then the third, and I think I touched on it a little bit, is feedback, right? Feedback is typically what you did right and what you didn't do right. In fact, if you look at some of the surveys from journals of education and evaluation of health professionals in 2020, the feedback actually tends to be a negative according to students. They feel senses of embarrassment, anxiousness, frustration. They're not really getting what they need to further develop those soft skills. I took a lot of time to really sit down and write down and give key points. But again, how much can you do in a 10-minute block with each student, trying to teach them what they need to improve upon? It's extremely difficult.
Yeah, it absolutely is. I mean, these are very powerful barriers, but at the same time, OSCEs are super powerful when they're used effectively. So, can you tell us what are the consequences of of these barriers? Essentially, what are the consequences of students not getting enough practice? And how is their confidence affected, and their ability to handle real world situations when they actually are faced with patients and they hit the clinical part of their schooling?
One of the fascinating things that I always tried to do when I was grading students with OSCEs was I asked what we can do better as leaders, as administrators in presenting these OSCEs. And I constantly got feedback from the students about how stressed they were, how anxious they were, how they really didn't feel prepared, how difficult it was to remember, quote, everything, how little time they had. They always felt like they were under that pressure of time because these things are timed. A lot of them would be kind of midway through or kind of coming to the end of a discussion with the patient, and then the alarm would go off and they'd be like, oh, okay, well, I'm going to go talk to my attending and come back. Well, that doesn't really happen. It kind of does sometimes in real life, but with these OSCEs, that's a fail, right? That's not a good way to end a conversation with the patient. Oh, I'll be back, right? So they didn't. They also complained they didn't receive consistent feedback. So you can imagine that feedback from one professor saying that they did a great job and they hit these points, and feedback from another professor that observed another OSCE may not be in as much detail. Maybe they didn't get feedback in person at all. Maybe they just got feedback on paper. So those kind of limitations really are a struggle, and when students run out of time, they really feel that pressure, and they can feel anxious about it. The other part is many OSCEs are very cookie cutter, right? So you get abdominal pain and headaches and high blood pressure, but without practice, these students really can't fully utilize their clinical knowledge that they've been obtaining over those first 2 years. They have to be able to take that clinical knowledge and communicate it to the patients, right? And in a one and a done situation in an OSCE, they may have a bad day. They may not have slept the night before. They may have been on call with the surgical resident overnight. All of those factors do come into play. So they don't really get that ability and be able to really focus their best on these things. And with that in mind, the other thing that's absent a lot in these OSCEs are having difficult conversations, right? How do you talk to a patient who doesn't want to do insulin? How do you talk to a parent whose child's labs that they've given on the sheet for the OSCE has cancer, right? How do you teach that, especially if they haven't experienced it before? OSCEs are typically cookie cutter, as I said, and students then end up having to learn from observation of others. If they learn from a great teacher and a great clinician, they're going to learn the right way and help develop their own clinical skills. But as you can imagine, all had I'm a physician, and I'm first to say we've all had those experiences with other physicians where, like, wow, I don't think they heard anything I said. Wow, that really wasn't the right way to deliver that information. So they're kind of learning on the fly, and that's really not the right way to learn medicine, and especially in that world of the art of medicine of communication.
Yeah, absolutely. And over the last 5 to 10 years, especially, there has been a big push of integrating various types of technologies, simulation technologies, into medical education, specifically around clinical reasoning. A lot what OSCEs assess and evaluate. Can you tell us a little bit more about how has simulation technology been used, let's say, over the last 5, 10 years in healthcare education?
Sure. I think the niche that we're seeing, especially with something like Xuron, is being able to practice, right? I'm a pediatrician, so I always say practice makes progress. Whether you're learning to walk, whether you're learning to read, practice makes progress. Practicing in the virtual sphere does matter, and it does help because you don't want to practice how to deliver bad news on a real patient, right? You want to practice how to do that the best, how to have empathy, how to show concern, how to emotionally meet the patient's needs. And I think that Xuron AI is starting to bring that into fruition, allowing these students and residents even to practice to be able to deliver information and take that clinical knowledge that's so vast and really break it into a definable rubric that they can then get really specific feedback for and improve on their skills.
Absolutely. So traditionally, simulation, especially within healthcare, uh, required a lot of time, a lot of money, a lot of effort. And it required educators to think of all the possible scenarios that a student could go through. And it was a big headache, to be honest with you. And over the last few years, with generative AI becoming widespread and cheaper, um, I've been seeing a lot of integration into simulation. Could you tell us a little bit more, and especially like how does Xuron integrate generative AI, both for the simulation aspect as well as for the feedback component?
I think one of the leading parts that you kind of mentioned was that it's a lot of time. You're actually getting patients, mock patients, to be present. We're not trying with Xuron to completely remove that patient OSCE experience, right? We're just trying to have a way virtually through a AI generated patient to have these students be able to practice, have them be able to work with those patients, to talk to those patients, and then get feedback. The other beauty about Xuron's OSCEs in its design is they can take rubrics from academic centers, create a virtual patient centered around that. So exactly what the academic program is looking for, create a generative patient in that regard. But the other part about that that's not really occurring in these OSCE formats of real patients is Xuron AI's platform allows education. So on the front end of these virtual patients, there's a kind of Quizlets of what do you know already about certain conditions? What can we help you learn more about so that when you walk in and now you're going to be talking to the patient, how can you do better about delivering bad news, for example? Or how do you really focus on abdominal pain with fever? And then on the back end, it gives feedback, but it also kind of does that post assessment. These are things that don't happen traditionally with OSCEs, but having that full spectrum of education through Xuron's AI OSCEs is really, really groundbreaking and really something that medical educators can see and students would love to be able to utilize.
Absolutely. And it just allows students, residents, anyone in training to essentially practice anytime, anywhere, as many times as they want to. So when the time comes for the actual OSCE on chest pain, they will come in with much higher confidence and hopefully perform better and actually learn more now that they've had that foundation after practicing as many times with an avatar. Well, Dr. Gunter, thank you so much for your expertise. This was a very insightful. So maybe to just kind of sum up, what would you say would be like the biggest takeaways in regards to how OSCEs or how assessment and evaluation of clinical skills are changing?
So whether you're a nurse or a medical student or physician assistant, nurse practitioner, or even a physician that's actually completed training, there's always room for improvement. The way we improve is practice and constructive feedback, right? Without both of those things being part of our continuous learning curve as we go through medicine, um, we can struggle. And what Xeron AI is trying to do is bridge those gaps of time, of cost, of education, and really more consistent feedback that's meaningful to help develop these physicians. It's also very scalable. If you think about it, the Xeron team could create an OSCE and release it en masse to numbers of students within a program. Hundreds of students at a time, as opposed to, okay, we've got this group on this rotation, we've got to arrange this room, we've got to get this done. Now we need to go in next 6 weeks. Here's another group, we got to do it. This is something that's massively scalable. It could help their soft skills. They can still do in-person OSCEs, but they'll have a better preparation for them. When they get into the real world of practice, right? They'll be able to practice. Think about this. If a physician today receives a bad score on their patient satisfaction, right? Leadership does call them, does email them like, "Hey, we got a bad patient satisfaction score. Do better." And that's honest to goodness the only feedback you get.
Yeah, it's
Well, what
amazing.
if that scenario that you experienced, and sometimes it isn't the physician. I get it, but sometimes you do want to improve and you do want to develop more, right? What could I have done better? We're always very self-critical as physicians. What could I have done? Well, maybe there's an husky out there of the same situation that I was presented with, and maybe I could do better. What if I was able to then do that OSCE as a physician, get more comfortable, get better at what I'm doing? The art of medicine cannot be lost today, and we all have experiences where we feel like it has. And I think Xeron AI generative OSCEs can really help bridge those gaps, improve education, improve feedback, and really develop the skills of our physicians and medical students and PAs and nurses across the board. And that's what I'm hoping for with Xeron.
Thank you so much, Dr. Gunther.
Thank you, Boris.
Awesome. I think you and I are ready for Hollywood.